Today I'm discussing the impact of COVID-19 on value-based healthcare. My name is Dr. Kathryn Antioch, and I'm the Chief Executive Officer of the Guidelines and Economists Network International. My co-authors are directors of the Guidelines and Economists Network International and include Angeline Kewick, John Pillar, and Rick Marshall. The purpose was to analyse COVID-19 impact on value-based healthcare globally using Porter's value-based healthcare framework to identify strategies to improve value-based healthcare in Australian hospitals. The methodology involves systematic review using PRISMA and PubMed and the Grey literature. The search terms were COVID-19, value-based healthcare, hospitals, Australia, reimbursement, Porter, risk adjustment, and activity-based funding. Turning now to results. Looking firstly at Porter's value-based healthcare framework. There are 6 key components, and as you will see as I work through them, many of these were impacted by the global pandemic. Number 1, integrated care organised around medical conditions, involving multidisciplinary teams managing care plans for full care cycle using outcomes and cost data to improve performance and an IT platform. 2, outcome and cost measurement for every patient. 3, value-based reimbursement, payments and rewards linked to value, not volume, provider accountability for quality outcomes, bonuses if targets are met, the implementation of best practice, risk-adjusted funding, for example, bundled payments by condition. 4, regional systems integration, providing the right care at the appropriate locations and by appropriate providers, leading to systems integration and volume concentration, leading to cost-effective healthcare provision. 5, geography of care and centres of excellence for complex patients. Additionally, a collaboration with smaller hospitals, service redesign best practice. And finally, and very importantly, information technology supporting value-based healthcare. The COVID-19 impact on value-based healthcare in Australian hospitals. Value-based healthcare is a very important component of the policy of the Independent Hospital Pricing Authority on hospital pricing and funding for quality and safety. There's funding adjustments for central events, hospital-acquired complications, and avoidable readmissions. Policy around preventable admissions is currently under development. COVID is impacted by increasing patient complexity, service delivery, activity levels, and models of care. The Australian Medical Association has indicated that in Australia, quality in Australian hospitals has been impacted by overworked staff last year and in 2022 COVID surges. Quality indicators may require revision. And importantly, risk adjustment, new care models, pricing, and artificial intelligence for COVID requirements in the UK and the USA are considered instructive for Australia. Sound COVID models of care for cost-effective value-based healthcare. Very important Australian models have been developed. Statewide ICU models of care for COVID, telehealth inpatient physician services, COVID-linked pathology testing, increased hospital in the home, adolescent mental health, drug, alcohol, and multidisciplinary case conferences. Private hospital agreement, which was finalised in April of 2020, has been a very important development whereby jurisdictions can draw on private hospitals, up to 57,000 nurses and 100,000 staff. There's been COVID-19 pricing impacts due to increased capacity costs, personal protective equipment, cost per patient increases, service delivery changes, telehealth, and hospital in the home pricing. Concluding by looking at global impacts on value-based healthcare during COVID. Importantly, looking firstly at risk adjustment. The UK's National Early Warning Score for COVID-19 risk stratifies patients. Hospital admission screening improved using blood and physiological parameters. Clinical risk prediction scores for COVID-19 disease progression assessments for COVID-GRAM scored 0.636, for call scored 0.5, for nomogram scored 0.628. I'd now like to turn to discussing risk adjustment challenges for US quality-based programs and value-based healthcare. Up to 40% of patients avoided care for acute and chronic conditions during the pandemic in America. This was due to concerns around virus transmission, stay-at-home orders, service reductions, loss of employment and insurance, deferring elective procedures, and resources diverted to COVID patients. Diseases that are very sensitive to gaps in care are diabetes, refractory hypertension, congestive heart failure, chronic kidney disease, ischemic heart disease, obesity, hypertensive cardiomyopathy, vascular disease, cancer, seizure disorders, Parkinson's disease, and several others. Several studies found negative effects by the pandemic on diabetes, venous thromboembolism, Parkinson's disease, kidney disease, and myocardial infarction, stroke, and cancer. From a risk adjustment perspective, a consequence of inaccurate assessments of health status, projected health needs, and costs need attention. This potentially impacts on US-based shared risk program models and value-based healthcare involving accountable care organisations, Medicare Advantage, the Affordable Care and Commercial Insurance Marketplace, ACT, the Merit-Based Incentive Payment System, CMS innovative programs, and several Medicaid programs. They definitely require accurate and up-to-date coding of conditions, enabling the projection of costs of care. Walter's Kluwer Health Language provides tools and services that assist providers and payer organisations identify at-risk patient populations and assist with determining severity of illness scores, such as the risk adjustment factor scores used by CMF in Medicare Advantage. Turning now briefly to other countries. Lower regular hospital treatments could result in fewer disease flags in morbidity classifications based on diagnosis for diagnosis-based cost groups in the Netherlands, the hierarchical morbidity groups in Germany, the hierarchical condition categories in America, and the indicator based on prior hospitalizations used in Switzerland. The Independent Hospital Pricing Authority could consider how such effects complicate the assessments of risk adjustment and payments to hospitals in the Australian setting. There's been some interesting developments in America concerning risk-adjusted bundled payments. Various stakeholders are really encouraging hospitals to partner with GPs and the private sector to develop risk-adjusted bundled payments for COVID patients, encouraging a transition to capitation rather than hospitals ending ACO contracts and moving to fee-for-service. Importantly, there's been new developments in pricing to reflect new service models. In America, orthopedic pricing reflects new service models stimulated during the pandemic by telehealth for non-invasive treatment strategies. And finally, and very importantly, artificial intelligence and telehealth. AI improves COVID patient screening, triage, diagnosing risk, care assessment and pathways. Big data artificial intelligence for COVID epidemiological trends, disease control plans, monitoring hospital surge. There's been some really interesting analyses of electronic health records using AI to manage COVID severity in patients and ICU planning. Thank you very much.